Good evening to one and all. Thank you for joining with us. On behalf of Nash 24/7, I welcome you all in today's live Facebook program. On the occasion of International Nash Day, today we are going to have an interactive session on fatty liver, what you should know. So on this occasion, today we have with us a renowned gastroenterologist, Dr. Vivan Talwar. Sir has done his MRCP and FRCP from UK, CCT gastroenterology from UK, and is currently a consultant gastroenterologist hepatologist at Talwar Hospital, New Delhi. Sir has chaired and sessioned in several national and international conferences and has numerous publications and research papers on his name. So on this note, without a further ado, I would like to hand over the session to Dr. Vivan Talwar.
Thank you. Thank you very much for introducing me so eminently. I'm not that eminent. But nevertheless, thank you. And thank you for inviting me to this talk. As you said, it's an interactive session, and that's how I would like to proceed. I would like to just talk a very small amount on NASH. I don't want to go into any technical details. I'll try and keep it as simple. And I think after that, we can move on to a question answer session, which I think is something more useful to the people out there hearing. I think before we actually go into the talk, I just want to clarify that when I say NASH or when I say fatty liver, I think I'll try and differentiate between two entities. The first one is, let's call it a NAFLD or fatty liver, and that's basically fat in the liver. That's it. So I'll try and stick with fatty liver and NAFLD, meaning just fat in the liver. And I'll try and use the word NASH, which is basically fat in the liver with inflammation or fat in the liver with damage to the liver. So I'll try and keep it to just these two terms to try and differentiate, even though it is a slightly bigger spectrum. But again, just to recap, NASH or NAFLD, fatty liver or NAFLD is just fat in the liver, and NASH will be used in context with fat in the liver with damage to the liver. In terms of why we're talking about this, because of how common it is. In the world, it is thought that up to 25% of people have fatty liver, which is staggering. I mean, if you think of the world's population of 6 billion to 7 billion, you're talking about 1.5 billion plus people with fatty liver, more so in the Western world, increasing dramatically in India. And depending on which study you actually look at, fatty liver in India is up to from 10% up to 30%. And if you go into NASH, that is the damage in the liver with fat, you're looking at in India, maybe up to 5%, 6%, and worldwide up to 6.5%. So the numbers are absolutely staggering. That's not the only reason we are here today. The other reason we are here today is because in the past few years, we have, for the first time, got treatment on the horizon. It's quite nice talking about diseases that are common, but if you can't help the patient, it doesn't really help the situation. So I think in terms of talking about a disease, educate the population how to prevent it, but also to help treat the patients. I think that's very, very important. What causes NASH? I don't want to go to technical details again. I think it's more important to say that there are common associations with NASH, and that what basically means is that if you are overweight, you are more likely to have NASH or fatty liver. That's up to 70% of the population of obesity can have fatty liver, and up to 25% of the population can have NASH. So obesity is probably number one causal or associative factor. Other common ones would be diabetes, especially uncontrolled diabetes, and more commonly, I would say type 2 or drug controlled or non-insulin dependent diabetes. Again, with similar astounding prevalence of 70% of diabetics having NAFLD, and again, up to 25 to 30% even having NASH. There are a few other ones which are important. I'll talk about them more so in the question answer session. I'll just run through them out here today. Briefly, blood pressure, diet, lack of exercise, metabolic syndrome, which is something more complicated, genetics. So multiple causal factors, multiple association factors. Stick with obesity and diabetes as the top two. There's also something called lean NASH. Again, I don't want to go into technical details about this factor right now, but it's also something coming up which is worrying because young, healthy, thin, non-obese, non-diabetic patients are also getting fatty liver, are also getting NASH. What are the symptoms of either fatty liver or NASH? And the sad part is that sometimes and most commonly there are no symptoms. And I said that sad part simply because people who have fatty liver, people who have NASH, don't even know they have it. You know, if any disease causes symptoms early on in the disease, to some extent it's an advantage to the patient because it helps them reach the doctor early and it comes up and helps with the diagnosis so that you can treat the disease or arrest the disease, preventing it to further progress. But in NASH or fatty liver, mostly patients don't have symptoms. By the time symptoms come, it normally means that the liver is damaged to a huge extent. And by huge extent, I'm talking about 60, 70, 80% when you start getting part of the liver dying, what's more commonly called cirrhosis of the liver, in which case you can get fluid in the tummy or you can get itching or you can jaundice. But the early part of fatty liver, there's usually no symptoms. Some people get a mild discomfort in the tummy, in the right upper part of the tummy, but that's also not very, very common. When fatty liver starts, it goes through phases. So you start with a normal liver. The first phase is deposition of fat. So fat accumulates in the liver. Once it crosses a certain threshold, we say you've got fatty liver. Then you start getting damage in the liver from that fat. And by damage, I mean inflammation. So if you look under the microscope, you'll actually see swelling of the cells. So it's as simple as me taking, you know, a stick and hitting someone on the hand, and the hand swells up. The same thing happens in the liver. The cells swell up and the liver size increases. And when you start getting damage to the liver, that's when it starts progressing more markedly, and it starts causing irreversible damage, what we call fibrosis. Fibrosis is a bit like a knife injury on your hand. You know, in the first one day, you'll have blood coming out and you'll have some swelling out there, but you come back after 6 months, there'll be a scar tissue. And that scar tissue is going to stay forever. So that's what we basically mean by fibrosis, something which is more chronic, which is not going to go away. And that eventually leads to death of the liver, which is called cirrhosis. And even that's, again, in phases. So the liver doesn't die overnight. Parts of the liver start dying and it progresses. So you basically have this spectrum from normal liver to fat in the liver to NASH, which is fat in the liver with damage in the liver, going on to scarring of the liver called fibrosis, and then going on to death of the liver called cirrhosis. How do you diagnose it? And that's one of the problems. It's very easy to diagnose and it's very easy to miss the diagnosis because we can pick up fatty liver fairly easily on an ultrasound, but can we pick up NASH? That means, can we pick up the damage in the liver? Not always. And that's one of the problems we face. As doctors, we don't understand sometimes who's got NASH, who's got just fatty liver. There are some clues along the way. You know, if a person is, if the blood test of the liver test, and we are talking more in particular things like SGOT, SGPT, also called ALT, AST. These are, if they are raised, they point towards inflammation of the liver, they point towards NASH. But in NASH, you can also have these normal, and that's one of the problems. We don't know when the person is actually having active damage in the liver. There are some other blood tests that you can see, things like platelet count Inr. The problem with them is that by the time we start seeing changes in them, that spectrum I spoke about earlier has gone fairly high up. So you're looking at patients who have now probably passed NASH and have started reaching that permanent damage stage, that fibrotic stage. So it's difficult for us to know where the patient lies on the spectrum. The gold standard, of course, would be a liver biopsy, which is taking a small needle and putting it in the liver. Not a great test to undergo. It's slightly painful, has a very, very, very small risk. And doctors are averse to using it as a diagnosis because we never had treatments. So if I diagnose NASH by a risky procedure or by a painful procedure and then told the patient, look how clever I am, I've made the diagnosis, but I can't help you, it didn't make sense. So we've historically stayed away from fatty liver. Glad to say that more recently in the past decade or so, Various other modalities have come up, various other tests have come up. There's something called a liver elastography. You might have heard of, some people, as a fibroscan. It picks up the early and the late part of permanent damage of the liver. So that's a useful test. MRI uses a variant of it called MRE, which is a very, very accurate test, and it's a great test, limited by cost and availability. And a lot of calculative scores have come up in the past 10 years by various organizations, various research groups, where you feed in certain data numbers like SGOT or platelets or weight or age, and you can calculate a score. All these are predictive, all these are accurate to some extent, and all of these have flaws to some extent. So it is very easy to diagnose fat in the liver. It's very difficult for us to know which part of the spectrum you are on, basically speaking. In terms of treatment, as I said to you before, that there was not a lot of treatments. Now they are. But irrespective of the medication, no treatment should start under any circumstances without focusing on lifestyle changes. And I'll repeat that, because that is so important. No treatment should start without focusing on lifestyle changes. If you're obese, lose weight. The 5, 10, 15 kilos weight loss is substantial and will make a huge difference to the progression of the disease. If you're diabetic, control your diabetes. Have your sugar controlled as per a non-diabetic. Again, you'll stop the progression of the disease. If you have high blood pressure, get it under control. So, go exercise, go do walks, see a dietitian, lose weight, eat healthy, eat the right food. Don't drink alcohol. All these are important. In terms of other medications, you have the historical old vitamin E, which has got a place, it's got a role with some advantages and some disadvantages. More newer medication which came out was a group of drugs called SAMIs. Again, a bit controversial whether they work or not. And more recently, you've got the PPAR agonist, and one of them is what we will be talking about today, saroglitazar, which is, in fact, if I'm not wrong, and maybe the company can correct me, I think is the first drug in the world which has been licensed for the treatment of NASH. So these are the options we have, with lifestyle changes. In terms of why should we treat this, I've told you about how patients progress and they get cirrhosis of the liver. But actually, surprisingly, the most common cause of death in NASH and with fatty liver is actually cardiovascular. So more people, in fact, up to 2 or 3 times more than would die with liver disease, will die from heart disease or strokes or any other disease related to the cardiovascular system, including kidney disease. And that basically goes again to show you that how it is linked to all these associations of obesity and diabetes and so on and so forth. I'm going to stop here because I could talk forever and ever. This is a topic which goes on forever. But as I said in the beginning, I think it'll be nice to get some interactive questions so I can help the people out there. With the provision, if I don't know, I will say I don't know. Thank you.
Thank you so much, sir, for such a lucid talk and very well explained in a very simple language. So, sir, getting some questions, sir, I'll take it up one by one.
Please.
So, the first question is, sir, if I am thin, do I still have chance of getting fatty liver?
Yes, and I briefly touched on this, didn't I? So there's something called lean NASH, and it's unfortunately becoming more and more common. And if I'm not wrong, it's actually becoming more and more common in men, which historically has always been. NASH and fatty liver historically have always been more common in younger men, and it gets more common in older women as time goes by. But yes, there is a non-obesity, non-diabetic, you get these young 25-year-old guys coming into clinic, absolutely thin, healthy, good lifestyle, and they are getting fatty liver. So why it's happening, we still don't understand, but it's happening, it's increasing. And it's a concern because these people are not necessarily screened for fatty liver.
Okay. So next question is, my CAP score is 378 and my KPA is 6.3. Is it serious? What should I do to reverse it? My weight is 130 kg.
So, CAP score and KPA are basically different modalities of measuring fibrosis of the liver, basically different ways of measuring. Remember one thing, and I'll emphasize this, that unfortunately fibroscans or this fibrous measuring scores are used to monitor disease, and it's not very accurate on its own. And don't get me wrong, I'm not dismissing the investigation. It's a great investigation, but it has to be used in conjugation with other things. And the reason I'm talking about this is because quite often, as you said, my CAP score is 350 odd, and the next time the patient comes and it's gone to 360. It doesn't work that way. You're not looking at small changes. But yes, a CAP score of 350 is worrying, and it basically means that you have got some element of possible, irreversible liver damage. That means in the spectrum, you are somewhere past the Nash or Nash fibrotic stage or something. The biggest clue in your question was the weight. I don't know your height, but I'm assuming 130, 140 kilos. Even if you were a 6'2", 6'3", you're overweight. So I think without doubts, it would be worrying. In answer to your question, how do I reverse it? Lose weight. And I know that sounds so blatantly easy, and how difficult it is. Only an overweight person would be able to answer that. If losing weight was easy, there would be no one in this world who would be obese. It's as simple as that. But I tell everyone, losing weight is not a 100-meter race. It is, don't go on crash diets. It's a slow process. Even if you aim for 1 kilo a month, and that sounds trivial, but even 1 kilo a month is 12 kilos a year. I mean, that's, in 2 years' time, you're down to 100 kilos. And it's easier to sustain small changes in your life. So if you, eat 2 chapatis, eat 1.5. If you eat parathas twice a week, eat parathas once a week. If you go for a 10-minute walk, go for a 15-minute walk. Small changes to aim for that 1 kilo weight loss. But the bottom line is lose weight. If you cannot lose weight by normal ways, see your doctor for alternatives to lose weight. And I'm even talking about medication and surgery. And that may sound extreme, but 135 would be so overweight that anything and everything you can do to lose weight will change your prognosis and your lifestyle.
All right. So the gentleman has also mentioned his height, 5'11".
Okay.
So yes, sir.
Carry on.
So the next question is, my SGPT was 158 and my SGOT is 135, but it returned to normal limit in 1 month. I'm currently suffering from fatty liver grade 2 and I am on hypertension medicine and I'm taking Hepakind 300 twice. What other things should I take care of, or what other things should I do?
Could you tell me what Hepakind contains? It's obviously not the pharmaceutical name. Do you know anyone what Hepakind contains? I don't know what Hepakind. Let me just check if I can find it. I don't know what Hepakind contains.
Ursodeoxycholic acid.
Ursodeoxycholic acid.
Yeah.
Okay, so first of all, great news that your SGPTs come down. I'm actually surprised that it's come down with Hepakind, because ursodeoxycholic acid has not been shown to help in fatty liver. So I'm assuming that something else must have happened, maybe a lifestyle change, maybe dieting or exercise. I don't know, but the fact that your SGOT and SGPT have come down is a good marker. Could you repeat the second part of the question, please?
So the question is, he's taking Hepakind 300 twice. So what should he do currently to take care of himself or to prevent grade 2 fatty liver?
Well, so his SGOT, SGPT have come down, which is a good sign, but it doesn't mean that you haven't got actual damage in the liver still. In the scan, as you said, you've got grade 2 fatty liver. I don't know if you're overweight or not, but again, number one, single most important factor out here would be try and lose weight out here. Keep a close eye on your SGOT, SGPT, maybe every 12 weeks. I don't think more frequently is of any use to anyone. I would go back to your doctor and discuss the use of Hepakind with fatty liver. I'm not convinced it works. And there's not much data suggesting that. And I know that does not sound sensible, because you lost your SGOT, SGPT have come down with Hepakind. But again, I don't think it's worked. I think something else you've done, which has actually helped. But it doesn't matter what you've done. Great, it's come down. But keep an eye on the SGOT, SGPT 12 weeks.
Okay. So he's also mentioned the diet change and lifestyle. Yes,
Sure.
sir.
I don't know how obese he is. That's the point I'm making. That I don't know his BMI and all that.
Okay. So next question is, what food should we take to avoid fatty liver?
Healthy home cooked food overall. So number one, stay off alcohol. Number two, low fat diet. So that is probably the mainstay of anything to do with making sure your liver does not progress to fatty liver and to go onto Nash. Overall, I would say that a healthy home cooked food, you can sometimes get into the nitty gritties and go to a dietitian and they'll give you something as simple as a diet chart that you should be eating this food in the morning and that. I'm not convinced that's the right way. I think education about diet is more important than rather diet plan. So I would say healthy food, and that's reduce if you're non-vegetarian, reduce red meats. Try and stick to natural proteins like egg and lean chicken, lean meats like chicken. In vegetarians, again, use less oil, use the correct oil in food, and definitely no alcohol.
Right. So next question is fatty liver a genetic disease?
Yes, categorically yes. And I talked about something in earlier called metabolic syndrome, and that's one of the parts where you actually get a genetic aspect. So if you actually look at metabolic syndrome per se means abnormal metabolism in the body. So your body functioning, the rate at which it functions is slightly different to how it should function. And you'll end up with certain factors. So you'll end up with obesity, you'll end up with high blood pressure, your uric acid could be high, you may be prone to diabetes, and of course you may get fatty liver and you may get Nash. So that's one very strong association with genetic. Then we also know about the obesity being a genetic. So there are definitely associations with genes, especially in the Indian context, because in the subcontinent, metabolic syndrome is for some reason more common. You tend to get a lot of people who are shorter, slightly on the overweight side, with a very, very strong family history of diabetes or hypertension or fatty liver or a combination of 2, 3, 4 factors. And I feel bad for these people because it's very difficult for them to lose weight, and it's always a struggle against, it's a fight against nature, unfortunately. And it's important for these people, these families, to recognize that, because the process should start when the children are young, to train them, to actually to eat healthy and not become obese in the first place. It's all about lifestyle changes. It's all about exercise. It's all about diet. So in answer to your question, yes, there's a very, very strong association with genes.
Right. So the second question is very specific. The question is momos or common fast food are the causes of fatty liver?
So common fast food? Absolutely. Yes. I mean, burgers, pizzas, KFC, you must understand what they're using. They're using, it's mostly deep fried. I'll come to Momos in a second. So it's all deep fried food. And it's not just deep fried food. It's deep fried in fat, in oil, which is reused. And reused oil, typically, I don't know if people must have heard of this term trans fats, which became very famous in the past decade or so, past 10, 15 years. And they realized that certain kinds of fat, certain kinds of oils are actually worse. And that's basically what you tend to get more commonly in fast food. It's reused oil, which is high in what's called trans fats, which increases cholesterol, increases triglyceride, increases the risk of fatty liver, increases the risk of heart disease, you name it. In terms of momos, I think would be actually quite healthy because it's actually steamed food, number one, and it's usually either vegetarian or chicken. So as long as it's bought from a hygienic corner, I think momos, like any other food in moderation, is, I think, safe. Yeah, well, okay. Can you hear me?
Yes, sir. So, the next question is saroglitazar a choice of drug for fatty liver?
Yes. And in my practice, it's number one probably. And I don't say that because of the talk which I'm in right now. Can I ask you one question? Was I correct in saying that saroglitazar was the first drug in the world licensed for fatty liver? Is that correct?
Yes, sir. For NAFLD and Nash.
Yeah. So I think in the past 5 years, it's been the biggest change in my practice, and it's made a huge difference. So I think that rather than look at fatty liver as a benign condition, that means a condition which is, less likely anything is going to happen, because one of the reasons is that fatty liver will cause problems after many, many, many years. So a lot of patients don't take it seriously. A lot of doctors didn't take it seriously. So I think rather than looking at fatty liver and NASH as a benign condition, more aggressive treatment should start early. And again, I said to you before, lifestyle. And in answer to this specific question, my first line of treatment is saroglitazar. Because of its mode of action, it has a role in patients who have NASH, patients who have fatty liver, patients who have either of the two with diabetes, patients who have either of the two with high triglycerides, patients who have either of the two with diabetes and high triglycerides. So it's got this beautiful pan treatment effect, which not only helps in one disease, but helps across the spectrum of 3 diseases. And the data has shown that not only will it decrease your SGOT, SGPT, but there's evidence that it actually reverses fibrosis, which is a contradiction in terms, because I said to you earlier that fibrosis is irreversible damage. And amazingly, saroglitazar has actually shown that it actually can reverse early fibrosis in patients. So I think that saroglitazar should be the number one medical treatment option, pharmaceutical treatment option in patients who have definitely with NASH and possibly with even just fatty liver. Not to forget that, and I repeat this again, not to forget that the patients you must emphasize to the patients that lifestyle plays a far bigger role, because lifestyle modification can theoretically essentially get you off the medication. If you lose the 20 kilos, you may not even require medication later on in the treatment.
Right. So the next question is, does long-term intake of ursodeoxycholic acid help in improving NAFLD? And the second question is, also, is it possible for the total bilirubin and the AST markers to remain normal, but indirect bilirubin to rise above normal?
So I'll answer the second question first. Okay, let's answer the first question. Ursodeoxycholic acid is a very, 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 very commonly used drug in India and in the world. And the reason being, it's a very, very safe drug, very safe drug. And up to 10 years ago, we had nothing else to treat liver. For all practical purposes, we had nothing else to treat liver. So ursodeoxycholic acid was given not just for NASH, it was given for pretty much every single liver disease that a patient went to see his physician to. Unfortunately, it does not work. And ursodeoxycholic acid is a great drug in the right circumstances. And as far as I'm aware, the only universal acceptance of ursodeoxycholic acid is for something called PBC, which is a different disease of liver, which I won't go into. But there's been no evidence to show that ursodeoxycholic acid in the short term or in the long term helps treat fatty liver. There were some earlier trials looking at it, which showed some evidence, and that too in conjugation with vitamin E and so on and so forth. But overall, ursodeoxycholic acid is not recommended for treatment of NASH or for fatty liver. Is it safe? Yes, it is. But many things are safe in life. Just because they're safe in life, you don't do them. You only do them if they are safe and they're beneficial to you. So that's the answer to the first question. I speak too much, so I've forgotten the second question. Can you repeat the second question, please?
So the second question is it possible for the total bilirubin and the AST markers to remain normal, but indirect bilirubin to rise above normal?
Yes, it is possible. There are different kinds of bilirubin, and direct bilirubin and indirect bilirubin are essentially the two which are there. And when you look at your blood test, you will get 3 readings. You'll get a total bilirubin, which is a combination of direct and indirect, and you'll get the direct and indirect bilirubin mentioned separately. Indirect bilirubin does not signify liver disease. Indirect bilirubin actually suggests more commonly a blood disease. So if your bilirubin is normal and your SGOT, SGPT, or AST, ALT are normal, it means that you haven't actually got a liver disease. You've actually got a blood problem. And the blood problem can be minor, but nevertheless, if you see an indirect bilirubin, you should go to your doctor to find out how to take it further. In terms of can your AST be normal? Yes, it can be normal. AST, you must remember, is not just produced by liver. AST is produced by liver and by muscles of the body. So a raised AST does not necessarily mean that you've got a liver problem again. A raised ALT does mean that you've got a liver problem because ALT is only made by the liver. So we tend to look at all these parameters. The one parameter which you haven't actually asked me was the gamma GT. Gamma GT is again a blood test which you'll get in the liver profile. So if your gamma GT is normal, I think then you should always say that it looks like my liver is probably going to be normal. That's not a black and white rule, but generally speaking, gamma GT is raised in any liver disease. But in answer to your question, AST normal, bilirubin, direct bilirubin normal, yes, it can happen with indirect bilirubin being raised.
Right, sir. So if you allow, sir, we have a couple of more questions. Yeah. So the question is, I am having a grade 3 fatty liver and my FibroScan shows 14 kPa. My SGPT is 70. My SGOT is 86. I am non-alcoholic, but I am having chronic pancreatitis, but my amylase and lipase is normal. Please advise.
What is, you said what is the weight and the height? Do you know?
No, sir, it's not mentioned.
Okay, so
weight and height are not mentioned.
Okay, so I think if you've got fatty liver in grade 3 and you've got evidence of inflammation with your raised SGOT, SGPT, I think then if you're overweight, definitely lose weight, exercise, eat the right diet, go and see a dietitian. Lifestyle changes, exercise is very, very important out here. That's the first thing. I would even recommend starting saroglitazar as medication. Some people even add vitamin E. I'm not averse to it. I sometimes use it, but I normally start with saroglitazar and I monitor it after 12 weeks. And depending on the results, I sometimes add vitamin E. So I think in your case, because of your comorbidities in terms of your chronic pancreatitis and because of both the changes on the ultrasound showing grade 3 and in the blood test, I would actually go along with lifestyle changes. I would start medication in your case. The other thing is the chronic pancreatitis. You said amylase lipase is normal. Again, different talk, but I'll just briefly touch on this because in chronic pancreatitis, it means that the pancreas have been damaged in the past, and now you've got the scar left in the pancreas. So typically in chronic pancreatitis, we don't see raised amylase lipase. That's normally seen in acute pancreatitis. I think I also got a message on my screen saying that the patient's weight is 85, 173 height. So that would be, again, maybe about 10 kilos overweight. So yes, weight loss would be as important as anything, but I would also add medication in the form of saroglitazar to this gentleman or lady.
Right. Sir, we'll take the last question. The question is, sir, as advised, I am taking a Biopsy and on doing ultrasound, it shows grade 1 fatty liver. So what do you think? Shall I continue the same tablet?
So Biopsy is saroglitazar. It's a difficult question because I don't have enough information, but let's answer the question in two scenarios. So if you were overweight, or diabetic or having a comorbidity and you've got grade 1 fatty liver, I might carry on with saroglitazar, that's Biopsy. I think if your liver function was normal, you were not drinking alcohol, and your risk factors were low, I might not give it in just grade 1. Again, I don't have enough information. I think I would need to know what the liver profile was, what the alcohol status was. So I'm sorry, I don't want to give you a wrong answer without having all the information out here. Okay, so I've just got a flash overweight. So yes, I would in that case, maybe I would give it for a short time and see how it goes. But I think more important in your case would be to lose would be to lose weight. If the SGOT, SGPT are high, I would definitely then continue with saroglitazar a bit longer.
Right. Thank you so much, sir, for addressing all the possible queries and for such a wonderful and interactive session that you delivered. And I'm sure this session would be very helpful for the patients of fatty liver and their caregivers as well. I would also like to thank all our participants for their active participation. And to know more about liver health, fatty liver, NAFLD, and Nash, do like and follow our page nash24/7.com. So thank you so much. Thank you, everyone. Thank you, sir, once again.
Thank you, everyone, as well, from my side. Thank you. Bye-bye.